All right, it's 7 o'clock. Let's get started. Hopefully, people will join us as we're going. Let me welcome everybody who's here. First of all, this is our first Zoom meeting, the first meeting since the pandemic started, and it's a joint meeting of three support groups. The Central Jersey group that meets in Freehold, and that's been meeting for 22 years. The Greater Philadelphia group that meets at Lankenau Medical Center, and the Greater Philadelphia group that meets at the Giant Food Store in Willow Grove. Our speakers will be Dr. Cheng, a movement disorder specialist, and we'll tell you more about her in a few minutes. I want to tell you a little bit very quickly about a few things concerning dystonia that have been in the news recently, because these are really important as far as treatment and research. Firstly, a company called Revance Pharmaceutical has been going through clinical trials of a botulinum toxin injection. That's like a Botox. Botox is a brand name and was the first one approved in the United States. And there are some others approved in the United States now. And the thing that's common about all of those that are used at this point is that every 3 months you have to get another injection. It wears off. The Revance for a botulinum toxin injection has been proven in 3 phases of clinical trials to last 6 months or longer. The good news to that is you only have to get injected twice a year. You don't have the downtime as often as you have where it's wearing off and then it has to start taking effect again. And it should lower the cost also. But approval from the FDA has been postponed because the FDA has to do an on-site inspection. And with the coronavirus pandemic right now, they haven't been able to do that. So that has been postponed slightly. Hopefully, they'll be able to do it soon. Another thing that I want to tell to all of you who have been getting botulinum toxin injections, if it's paid for by Medicare, there's been a change in the regulations at Medicare that are actually in your benefit. Until recently, you couldn't get botulinum toxin injections more frequently than every 3 months and have Medicare pay for it. Recently, though, Medicare has changed the policy, and if your doctor writes that it's a medical necessity for you to get the botulinum toxin injections more often than 3 months, more frequently, they will approve it. My daughter has been getting her last sets of injections every 10 weeks apart. That's the last 3 sets, not every 3 months. And that eliminates those couple of weeks of downtime and then getting up again as it starts taking effect. So that's very important. So if you are getting it paid for by Medicare, speak to your doctor about it. And Medicare usually sets the pace for a lot of insurance companies. So if other insurance is paying for it, you might see differences in that also. The last thing that I want to talk about, and this was reported in the Dystonia Medical Research Foundation's Dystonia Dialogue magazine recently, is Dr. Cheng is going to speak about the ways that doctors determine now if you have dystonia. But there's a new technology with artificial intelligence, AI, that's being tested right now and is proving to be 99.8% successful in the tests. And that is a test wherein with an MRI of your brain, within 1 second, they can tell if you have dystonia or not. Now, at this point, again, it's still in trials. It's only for a specific type of dystonia. There's going to have to be a lot of more testing, but that's a really important and significant improvement because you might be able to get tested, or other people who have dystonia might be able to determine if they have it or not based upon that test that is 99.8%, 98.9% effective, and it takes only 1 second to get the results. Now, the one thing I want to mention quickly before we get to Dr. Cheng is there's a lot of research going on in dystonia, in better treatments, in finding a cure. But with the pandemic this past year, a lot of the research money that has been available, a lot of the fundraisers that normally would have been held, haven't been able to be held. Now, the Dystonia Medical Research Foundation, under whose auspices we and most of the other support groups in the country operate, also funds initial research and gets a lot of young scientists involved and interested in researching dystonia. Funds are down this year, and that's really scary because there's research that started already that has to go on. There's more research that we need to be done. You can join the Dystonia Medical Research Foundation for $40 annually, and those funds will go to help research and to help the support groups. The Dystonia Medical Research Foundation, I will tell you, operates on a very, very small staff. The agencies that rate charities rate it way, way up there. So most of the money that comes out of that $40 goes to research and to support groups and to awareness projects. So I will send you a link in a follow-up email, and I urge you to please, please, please join the Dystonia Medical Research Foundation and renew that membership each year, because that helps research, it helps get scientists interested in getting them started in research, and it helps the support that we're providing to you and the awareness that we in the foundation provide. Our speaker this evening, is Dr. Cheng. Dr. Cheng completed medical school in China, then completed a neurology residence at Cooper University Medical Center in Camden, New Jersey, and had a fellowship, a movement disorder fellowship at the University of Maryland. She is going to speak to us about diagnosing dystonia and treating dystonia. Dr. Cheng, thank you, and the floor is yours.
Sure, pleasure. Thank you for the invitation as well. I hope I can use my training and skills to help as much as I can. Okay, so to the point. So basically, dystonia, that is the third most common movement disorder worldwide. By the way, if you are curious what's the first and who's the second, so the first one is tremor, and the second one is Parkinsonism, including Parkinson's disease. And so, so basically, dystonia is the third one, and it's almost like 20 times more popular than common Parkinson's disease. So that is clinical findings, and it's a syndrome, and it's a disease entity. So first of all, what is dystonia? By definition, dystonia, that is a sustained or intermittent muscle contractions that cause abnormal movement, postures, or could be both. And this is often repetitive. And this kind of movement or posture are patterned, twisted, and sometimes could be tremulous. And this is often worsened by voluntary action or some movement, and associated with some overflow muscle activation. When I mean overflow, that means when you're trying to do some action and some muscle unwanted area and make it activate as well. For example, you're trying to reach a cup, and the only muscle you need maybe just shoulders, arms, and hand. However, with overflow activation, sometimes your head or your neck, the muscle can be activated and form some sort of posture or movement. So that means overflow muscle activation. So as a clinician, how can we diagnose the dystonia? So basically, I would say, yes, we do have some other testings, brain MRI or EMG, but basically that's pretty much a clinical, sort of diagnosis. So, and the way diagnosis go by the hallmarks or very specific clinical presentations. A couple of things. First, this is a pattern. There's a patterned nature of the symptoms that's sort of stereotyped. That means you go by certain pattern, repetitive, involving usually the same group of the muscles. For example, you have hand dystonia, usually involve one hand, sometimes could be both, but one hand became like a twisted in certain posture, or could be tremulous movement in certain movement. So it's sort of very similar pattern each time. And the second, this could be sustained, or even it's intermittent, but during that window time is sustained. So it's a sustained abnormal postures. So it's not like other movement disorder could be randomized, other that does not fit any certain pattern. And the next things, next thing I would say, dystonia is often activated by voluntary movements. Sometimes could be task specific. For example, very well known writer's cramp. So it can be those dystonia on the hand can be activated by writing. So we call writer's cramp. So it's activated by voluntary movement. And the next thing, clinical features could be sensory tricks. That means the dystonia, for some reason, can be relatively relieved by touch. But this touch has to be yourself. Usually won't work if you be touched by someone else. For example, the cervical dystonia, the neck. If you use your hand, touch one side of the neck, sometimes they can relieve the dystonia. You probably know about this since you have some experience. So we call the sensory tricks. So above the features as I mentioned, so it's the key clinical features leading to the appropriate diagnosis. However, so dystonia, I mean, it's sort of common, but it's not very common disease. So if you go see primary care doctor or some physician provider not specialized in neurology, so sometimes could be very hard to leading to the diagnosis. And even general neurologists, not in the specialist movement disorder, sometimes can take a really long time or hard time to diagnose the dystonia because you have some mimicking. I will talk about that a little bit later. All right. So since we mentioned the diagnosed difficulty, so what else can mimic the dystonia and leading to, the diagnostic dilemma? First thing, a couple of examples. Let me just give you. First could be a tremor. Sometimes there's a condition we call the dystonic tremor, especially on the neck dystonic tremor. That could be very hard to distinguish between just the tremor, even dystonic tremor versus cervical dystonia. And the key to diagnosis, that could be a few features I mentioned a couple minutes ago. For example, sensory trick or any repetitive, sustained muscle activation, which can be visualized this discharge by the EMG. So if I see a patient with sustained in some posture of the neck and show very burst of the discharge on the EMG, telling me the overactivation, I might think about this is cervical dystonia rather than dystonic tremor. Okay, so that's tremor. The second one could be mimicking the dystonia, could be chorea. Chorea, that's a medical term, means dancing like a movement. So someone with Huntington's disease, I don't know if you ever heard, probably you do hear about this. Chorea is a dancing movement. Sometimes the Huntington's disease, they have it. So chorea, dancing movement, usually is unpredictable, it's unpatterned, it's randomized, could be anytime, anywhere of the body, it's unpredictable. So it's not like a dystonia, usually it's patterned, stereotyped, usually in certain pattern of the movement. So that's chorea. And next thing could be mimicking the dystonia, could be myoclonus. When I mean myoclonus, that means sort of muscle jerky movement. So the key thing, as I mentioned, is jerky movement. So if you see the jerky muscle jerk, so that usually leading to diagnosis myoclonus, not dystonia. Because dystonia, sometimes they could be a little jerky, but usually it's not that jerky as myoclonus, and it's a sustained muscle contraction. It's less jerky than idiopathic myoclonus, and you show different pattern on EMG as well. So that could be a very distinguishing things between these two. So I think I mentioned a few examples, and so what's the most common condition can be mimicking dystonia. I think let's go to the each specific clinical condition. I think the most common, I still would say, is cervical dystonia in adult. Most common dystonia syndrome is a cervical on the neck. So usually onset around young or middle age, could be erupt on site, and usually it's mild at the first beginning and can be progressing in the next couple of years. So, and usually this cervical dystonia, you will have some neck pain, and because your muscle is always overactivated and in certain twisted position, usually more common in female, and you can have some shoulder elevation as well. So, so in cervical dystonia, and usually the misdiagnosis in this case could be some neck strain, some herniated disc on the neck, or could be some just arthritis on the neck. That's a common misdiagnosis, but go by the certain features and also sometimes MRI and EMG. I would say the most case, not all, but the most case we can distinguish between these two. I mean, the cervical dystonia and herniated disc, severe arthritis, or neck strain. In most cases, we can distinguish. So that's about cervical dystonia. And another common thing, dystonia I want to mention is the Dopa responsive dystonia. So that's very common in children. So it's childhood onset usually, more common in females. So in this condition, and usually we have clinical features such as diurnal fluctuating. When I mean diurnal fluctuating, that means during the daytime and nighttime, you can have a little bit different severity and intensity. Usually it's mild in the daytime and worse at nighttime. And also this condition, such, the name probably can tell you, is the Dopa responsive dystonia. Usually give some trial of levodopa that can be very helpful and much improve the symptoms. And in this condition, common misdiagnosis, I mean the Dopa responsive dystonia, the common misdiagnosis could be cerebral palsy or some myopathy. When I mean myopathy, that means some sort of primary muscle problem, muscle disease in children. So that's common misdiagnosis. So with time, this kind of condition, sometimes children can outgrow of this condition with the levodopa treatment, and when they grow, and this condition sometimes can be in remission for a long time. But if this kind of condition happen, onset in the adulthood, could be some Parkinson's, part of Parkinson's disease. So that's another different story. Okay, so that's some general picture about this Dopa responsive dystonia. So I think next thing I want to talk about, just a brief about the workup. What do we do to diagnose this? So first of all, still the clinical syndrome. We see the patient and make the clinical diagnosis and judgment by the hallmark of the presentation. Sensory tricks, overflow muscle activation, activity, overactivity discharge on the EMG. And also sometimes we do brain or cervical MRI to see if there are any possible structural lesions. So that's pretty much most common tools we use to for the diagnosis. So that's about the basic things, common rules in a diagnosis. So when we try to diagnose dystonia, we may also want to think about some secondary cause, because all the things I mentioned is primary. When I mean primary, that means basic much that's from nowhere. That's as a first place, it just happened. And if I mean secondary, that means you have some disease with medical condition at the first beginning that lead to dystonia eventually. So in that case, we call it secondary dystonia. And the common reason leading to the secondary dystonia that include stroke, brain tumor, trauma, some medication, drug-induced, especially antipsychotic medication that can lead into dystonia, or underlying systemic malignant disease, and you have sort of autoimmune problem, and you can have dystonia. Or could be psychogenic, functional. That means for some reason you have dystonia as one of the response to certain distress. That means functional or psychogenic. So that's the common reason leading to secondary dystonia. Next one, I want to talk about briefly about what do we do for treatment. So before I mention specifically what kind of medication, what procedure we can do, so I want to give you a general picture about the treatment. So at this stage, I have to say, with a few exceptions, so at this moment, we do not have specific pathogenesis guided therapy for dystonia. When I mean a few exceptions, that means I'll give you a couple of examples later on. But so far, we don't have pathogenesis guided therapy for dystonia. And the second, at this moment, the evidence from a large-scale, double-blind, placebo-controlled trials is very limited. We do not have enough clinical trial to support certain medication exactly gonna cure the dystonia. So all we do now is a symptomatic control, and including the Botox or other medication we can talk about later. That's all trying to relieve the symptoms, to help with the abnormal postures, abnormal movement, to help with the pain or certain discomfort, those kind of things. And also, of course, the therapy must be individualized and tailored to each patient, because everyone is different. We have to think about different things when we're trying to pick each certain medication for the patient. So that's the general rule of thumb regarding the treatment. So, okay, so now what do we do specifically? So as I mentioned, except for a few exceptions. So what is the exception? We do have specific pathogenesis guided treatment for dystonia. A few examples. One common thing could be a Wilson's disease. So Wilson's disease, that means, so usually it's the gene mutation leading to copper transportation problem in your system. So dystonia could be one of the presentation or clinical features in Wilson's disease. So since we know what is the pathogenesis, well, copper transportation problem. So what we do is try to target on the copper transportation, and then we give penicillamine, those kind of chelating medication to try to calm down this copper transportation. So that's one example. We do have specific goal and what we can use to target the goal. And another example, specific, for example, dystonia and unsteadiness with vitamin E deficiency. Well, so that is a sort of vitamin E transportation problem as well. So what it would do, simple vitamin E, give them whatever, got some problem. So to calm down the dystonia. So that's another example. So besides those kind of things and all the other things I'm gonna talk about now is a medication or Botox. It's just trying to relieve your symptoms. So the medication, I would just try to pick a few examples, common one. So usually the medication, we have a different category. The first category were the most common one, or at least most, I would say, could be useful, at least wouldn't hurt to try, gonna be carbidopa, levodopa. So carbidopa, levodopa, we call it, fits in the category of dopaminergic therapy. So remember, as I mentioned, it's a dopamine responsive dystonia. So in those kind of situation, we will try this medication, and most of the case, they will be responsive. So because basically in those conditions, the primary abnormality is the deficit in the dopamine transportation problem or synthesis problem. So we give dopamine to calm down the dystonia. So that's category 1. And so category 2 medication is anticholinergic. So the well-known R10 or trihexyphenidae or cogentin, benzodiazepine fits in this category, anticholinergic. So for anticholinergic, usually it's pretty helpful in most type of dystonia. It's pretty marked, at least moderate, beneficial for most type of the dystonia, and then we can use for generalized dystonia. So the name, as I mentioned, trihexyphenidae, benzodiazepine, and sometimes Benadryl. Sometimes we pick this medication if we have primary generalized dystonia and the patient is not that old, have some cognitive impairment, or patient can generally tolerate this medication after a couple of weeks trial, and then we just continue. But bear that in mind, the side effect of the anticholinergic medication that include dry mouth, constipation, foggy mentation, sometimes very drowsy, falling to sleep very often. So if we notice this kind of the very bad side effects, or the patient itself is very advanced age, we worry about mentation, possible dementia at the first beginning. So that will have me, I probably wouldn't even consider to try at the first beginning, because I know the result probably is not that good, and the risk could be outweighed the benefit. So that's this category of medication, anticholinergic. So move to the next one. I would say Baclofen. So nowadays, Baclofen is not that popular as above 2, as I mentioned, carbidopa, levodopa, and anticholinergic medication, because number one is not that beneficial for the patient. This medication Baclofen, they can provide some benefit, yes, but just not that dramatic as above 2. Another thing is a side effect, because it's medication, common thing can make you very drowsy, sometimes cannot even be functional. But in some case, for example, if the patient has Parkinson's, and Parkinson's is related to dystonia, sometimes I would still consider use. And also one thing is in the last, I would say decades, some patients received the Baclofen pump that put in the pump and supply the Baclofen intrathecal. That means directly to your spinal cord. I think that's 10 years ago, that's pretty popular. So, but nowadays it seems like less and less popular, because one is because of DBS, it's a deep brain stimulation available. And another thing, it could be common side effect from this pump. And sometimes you can have the catheter leakage and leading to a lot of trouble. So it became less popular nowadays. That's about Baclofen. Baclofen, that fits in muscle relaxant category. So that's muscle relaxant. So next category, I would say sometimes we can try benzodiazepine. For example, Klonopin, the clonazepam, those kind of benzo, sort of sleepy medication. So this category of medication usually we use as an add-on medication, as a combination of something else. I barely use it at the first beginning or as a monotherapy. obvious is because sedation sometimes could be quite disturbing. You don't want to go sleep very drowsy, cannot even think during the daytime. So that's very obvious reason. And also, besides, we have carbidopa, levodopa, and we have anticholinergic, as we mentioned. Those things, you should, generalized speaking, work a little better than benzodiazepine in the setting of dystonia. Okay. So next one, Botox. So I think I have to correct myself. I think Janet, right, asked me the question about what's the max dose of the Botox. I have to correct myself. It's 400. It's not 250. But when why I keep the 250 keep in my mind, because my personalized experience, I've never so far I've never go beyond around 200, 300 dose each. I have never go beyond that. Beyond 300, I will be a little very hesitated, or I have to refer the patient to a territory big academic center, because beyond 200, 300, I would consider is a sort of a refractory case. But the maximum dose, as FDA approved, is 400 milligram. So Botox usually is is sort of a chemodenervation, so leading to the focal or local paralysis or weakness when we inject to the muscles. So so usually we do it every 90 days, 3 months or 4 months, because during that window time, 3 months, 4 months, and the medication is probably wearing off already. So we do the Botox, and we can use on the face, we can use on the eyelid, and we can use on the neck. We can use sort of everywhere on the body. So usually it's very well tolerated. It's pretty safe, I would say. So I have to use this word, remarkably safe, because the long-term side effect usually is not that much. So we have some, I think, as I can recall, in 2015, I noticed one clinical study, and they tracking the patient with over 10 years Botox injection. And the side effect, we do have some side effect, weakness, intolerance, muscle fibrosis changes, but usually it's mild and it's tolerable. So generally speaking, it's very safe. You can use even over 10 years, unless you develop, very bad intolerance, does not work anymore. Usually it's pretty safe, used as a long term. And the short-term side effect is focal muscle weakness, some very rare syndrome, flu-like symptoms a few days after injecting, but it's usually flu-like symptoms is not very often. It's only occasionally, unless you are allergic. So far, I haven't seen any, my patients, they are allergic to the Botox. I haven't seen, but I heard, but it's very rare. So that's about the Botox. The last category of the therapy is the surgical, surgical intervention, surgical treatment. And one thing I mentioned before is intrathecal Baclofen pump. I mentioned already. And another thing is a DBS, deep brain stimulation. We, put a stimulator into your brain and sort of take over the headquarters and then reset the frequency of the signal, and can calm down the overactivated muscles. That's pretty much in a nutshell, this DBS. This, I would say, in refractory case, if you do not respond to all kinds of medication very, very well, and you are potential candidates, yes, we do consider DBS. When I mean potential candidates, let me give you a few examples we would consider. First, we tried everything and doesn't work. And second, so your dystonia already gave you very bad, very bad pain and discomfort, or very debilitating, and make you cannot function. So that's second. And third, is that you're still like a normal person. You do not have any significant dementia or depression. So that's very important as well. And next thing is you are generally healthy. You are okay to do this procedure or operation, and you are not like a very bad heart condition, very bad lung condition, which will sort of automatically rule you out to even consider the certain surgery. So that's a few things we would keep our keep our patient informed when we discuss about the surgery or operation. So that's about the DBS. And other things, I think you probably everyone gone through already. Physical therapy, occupational therapy, that's can at least help you with the symptoms and improve the quality of life. So that's pretty much in a nutshell about the treatment. So I think I'm pretty much done with my brief introduction about dystonia. So now I think I'm very open to any questions or concerns you guys have.
Thank you, Doctor. Yes, we had our members submit questions in advance. We wouldn't have to have all the mics on and get it. A lot of people speaking all at once. Some of the topics that were people asked questions about, you've sort of covered already, but you might have things to add to that. And I'll read the questions in a moment. Just to let our members know, firstly, some people asked questions that were very, very personal about their specific situations. That's not really relational to the entire group, so we're not going to have the doctor respond now. However, Dr. Cheng has been very gracious, and she's told me that I can provide her email address to everybody in our support groups, and I will do that in a follow-up email. So if you want to discuss something personal with her, you can do it that way. But I will say, though, it's very, very important, when it comes to your own personal issues, everybody's different. It's really more important to speak to the doctor who's treating you, who knows you as a patient, because everybody is very different. All right, the first question, I'm sorry, there's one other thing I want to say before I read the question. There were questions about specific non-medical treatments for dystonia. And those are not things that I can ask a doctor to comment on, but you can do research online. I looked into the couple of treatments that people asked about, and they're interesting. There's not really much medical validity to them or research that's proving that they work, but there's anecdotal research showing that they work. People say, well, I did this and it helped me, to a certain degree. So you can look for things like that online. All right, doctor, among the questions that people ask, and I guess the first one relates to everybody, is does anybody ever get cured completely?
It's rare. I have to say there's the short answer is yes, but that's usually not the primary dystonia. That's usually secondary dystonia. So, for example, you had a stroke and then you got a secondary dystonia. Yes, that can be with time can be cured. Or you have some brain tumor, underlying cancer condition, and with the treatment cure the cancer, and then dystonia can be cured. Yes, but that's usually applied for secondary dystonia only. For primary dystonia, it's very rare. In certain circumstances, if you have, let's say, neck dystonia, cervical focal dystonia, and usually they progress for the first few years. And with treatments we provide, I mentioned those kind of treatment, you can be stabilized. We call it in remission for a long time. That can happen, but I wouldn't call that cured. I can only call in remission. And another thing, one circumstances we call quote cured is a dopamine responsive dystonia in children. So children on enough supply of the treatment, carbidopa, levodopa, and with years when they become like more mature and become heading to adulthood, sometimes occasionally they can outgrow the dystonia, but that's sometimes, not always. So in general speaking, I have to say, in the setting of primary dystonia, on average, so the cure or in long-term remission rate is somewhere about 5 to 10%. Otherwise, the large amount of the primary dystonia, we can only offer symptomatic control and try to reach the goal of remission, at least short-term remission.
Thank you, doctor. And just to add a little information to that, when the doctor speaks about primary dystonia, she's speaking about dystonia as the main cause or the cause of your symptoms. A secondary dystonia is a dystonia that's caused as a result of some other conditional illness that you have. And dystonia is sort of a side effect to that. All right, the second question I think you've covered already, but I'll ask it again if there's anything you want to add. Somebody asked, are there certain medications that help movement disorders more than other medications do?
You mean alternative medicine?
They're asking specifically about medications. And again, I guess that's really, you've covered it already. But if there's anything you want to add about alternative treatments or other medications, I mean, please go right ahead.
So I think some non-medication treatment. One thing is we mentioned the sensory tricks. So I think I mentioned that's one of the clinical features as well. So sometimes you feel too discomfort and too painful, certain twisted position, for example, on your neck, you can try to apply the hand on your neck. We call the sensory tricks. They can reduce the symptoms and reduce the painful spasm on the neck. We call the sensory tricks. That's one of the non-medical treatment. And another thing is heat or cold. You can apply some heat patch or cold patch on the muscle area, dystonic area. Sometimes they can help to ease the muscle pain and the twisted, we call it the postures. So sensory, heat or cold, or stress management. So you can go for some, for example, the meditation, yoga, those kind of the exercise can, I think in long-term run, can definitely help to help you how to cope with the dystonia and provide very positive feedback to yourself. So let me just try to summarize: heat or cold, sensory tricks, meditation, yoga. That's the thing I can think of for now, non-medical treatment.
Thank you. All right, the next is a three-part question from one of our members. Are the movements caused by dystonia progressive for the rest of our lives? Will they always worsen, or can they stabilize with time? And if Botox works, will we have to use it for the rest of our lives?
So most of the dystonia, they do progress, but usually they became onset, and in the first few years, let's say 1 to a couple of years until 3-4 years, they do progressive gradually, even with the treatment. And after the first few years, depend on the case, if the cervical focal dystonia, when I mean focal, that means involve only one part of the body, for example, on the neck. For example, the facial dystonia, only on the face, or only on the hand, writer's cramp. So usually after the first few years, they trying to stabilize. Especially with the treatment, they do not get any worse. Let's say 20 years, 30 years, no, they don't. But that's in the setting of focal dystonia. And another setting, if you have generalized dystonia, when I mean generalized, you have more than 1 or 2 area in your body is involved. For example, you have face dystonia, you have neck dystonia, you have arm or foot dystonia, all combined together. So generalized dystonia, primary. So usually they tend to progressive gradually over the years. It's hard to reach the long-term remission. So in that case, so usually for generalized dystonia, besides the medication we mentioned, yeah, we do Botox. And with Botox, as I mentioned, so usually it's pretty safe as long as you don't have much side effect. For example, weakness, very bad allergic reaction. You can continue this treatment for very long term, long term, even above 10 years. You can still continue. It's okay.
Thank you. And I just want to point out, and I've said it before, we use the term Botox generically because it was the first botulinum toxin that was injected in the United States. But there are 4 different brands that have been approved by the FDA at this point. And there is that one that I was discussing earlier by Revance that it was looking for FDA approval, and that's the one that will last longer. And you sort of know, although the other companies haven't mentioned it yet, that if one company is working on a botulinum toxin injection that can last longer than 3 months, 6 months or longer now, the other companies that have established ones already have got to be working on them too, because if not, they would lose a major part of their market share. So I think we could expect to see others coming along soon also. All right, the next question is a different one, and it's very interesting. Are there any foods or vitamins that affect dystonia? And are there any foods or vitamins that should be taken or avoided?
The short answer is no. I'm sorry.
No, that's fine.
So basically, at this moment, there seems like does not appear to be a direct correlation between certain diet or food or vitamin between dystonia and the diet and the vitamin. No direct correlation. So generally speaking, so if you really want some recommendation about your diet, so the bottom line, you pretty much just should have a very good nutrition support and nutrition diet to make sure you take sufficient calories, because consider amount of the muscle overactivation activity ongoing during the day, you might need a lot of calorie supplement. But a couple things I do want to mention. So some stimulants, for example, the nicotine, the cigarette, the nicotine, and caffeine in the coffee, sometimes for some reason they can make the symptoms worse in some patients. So if you could try to avoid smoking and try to minimize the coffee. Try to minimize. You can, but just not that much. And on the other hand, sometimes in certain situation, but I'm talking about some gene mutation situation, sometimes alcohol can make the symptoms better. So that's a myoclonus, the dystonia torsion. That's one of the inborn problem. And in that specific situation, sometimes you can take a little bit alcohol to reduce the dystonia temporarily. So that's a couple of things. And but bottom line, so far, the nutritional supplements or any certain vitamin has not shown any direct cause or any dramatic correlation with dystonia.
Thank you. And we've had nutritionists and dietitians as guest speakers at our support group meetings. And, basically what they've been telling us is eat a healthy diet, get your exercise, and that will help with everything. If it makes you stronger and healthier, it might help a little bit with your symptoms also. But, the healthier and the better condition you're in, the more you're able to cope with the symptoms. All right, the last question that I have, doctor, is are there any known long-term side effects of treatments such as injections or oral doses of trihexyphenidyl or Botox or any of the other things that are used for dystonia?
So the long-term side effect, if you mentioned the trihexyphenidyl, so long-term, I wouldn't call it exactly long-term, because if you have a very bad side effect, you're probably going to experience that a couple of weeks after the trihexyphenidyl. So trihexyphenidyl, you can make you very foggy, very drowsy, sometimes cannot even be functional, or the loss of bladder control or very bad constipation. And those side effects can kick in after a couple of weeks. So if it's bad enough, we simply just stop. So I have not seen any patient continue using this medication even with ongoing side effect yet. Not really, no. So I cannot comment on exactly long term, because once I see the severe, very bad side effect, just simply ask to stop. So for Botox, the long term, as we mentioned, usually is even over 10 years, you can still continue. But there's in 2015, we do have a review about the long-term side effect from Botox over, I think it's over 200 the patient, as I can recall. So the possible is a difficulty. Could be a difficulty swallowing if you have a lot of injection on the neck muscles, and you can have the droopy eyelid if you have multiple injection to the eyelid for eyelid dystonia, or some patient can have blurry vision because you have some long-term repetitive dose of the injection to the eyelid or surrounding the eyes muscles. You can have sort of the asymmetric weakness on the muscle innervates eyes movement. So you have a sort of asymptomatic eye movement that gives you blurry vision. Or some patient can have some generalized or marked weakness and after long-term repetitive injection. But as I can recall, or all the literary review, we still recommend, if you can tolerate and the benefits to outweigh the risk, go ahead. Over 10 years should be okay, unless you suffer from very bad the side effects, as I mentioned.
Yeah, and anecdotally, the botulinum toxins, Botox and the other brands, have been refined considerably since they first started injecting people with them back in the 1980s, actually, with Botox. So there are many fewer side effects and long-term effects now than there were when they first started injecting. And I can just tell you personally from our own family, my daughter gets Botox injections. She's been getting them for 27 years now, and it still helps her tremendously. But again, everybody is different. Doctor, thank you very much for your presentation. It was very, very informative. For those of you who are members of our New Jersey support group, Dr. Cheng practices at Central State Medical Center in Freehold Township. That's the hospital in which we've been meeting for 22 years, and we've been trying to get them to get a movement disorder specialist for 22 years, and we are thrilled that they have one right now. So Dr. Cheng is right there at Central State Medical Center. And again, she very graciously told me that I could provide her email address to everybody who's been at this meeting and everybody in our support groups, and I will do that in a follow-up email. So if you have questions for her, she's graciously offered to answer them. She might get swamped with them, so give her some time. You know, she's got to practice her medicine also. Other than that, this is the end of this meeting, our first Zoom meeting. I want to thank everybody who attended. We had a couple little hiccups in getting this thing operating, but we got through it. I think one of the things that we'll do, based upon the ease of doing a Zoom meeting, because we know so many people have spoken over the years of the difficulty of traveling to meetings, is we're going to break up meetings once we get past the pandemic. And we will have, of course, some meetings in person because people like that personal interaction. But we'll also have some Zoom meetings where more people can get involved. And another advantage of Zoom meetings is we can have speakers from way outside of our geographic area, and they can come on and speak also. So at this point, let me wish everybody a happy holiday season. Everybody, please stay home, be careful, be safe, be well, and we'll see you after the new year. So long, everybody.
Be safe. Thank you.
Bye-bye.